Hi, I'm Dr. El-Hajjar. I'll be talking to you today about the cardiology training in the cath lab regarding interventional and structural heart disease. I did my training here at Albany Med in cardiology and interventional cardiology. And you will see that when I did my training, we didn't do many of those things, but I was able to develop over the years with my colleagues, with the new technology and procedure that we do here. And we're doing all femoral cases, and we progress to do now almost all cases radially for the cath and PCI. We weren't doing any structural cases, and we built the structural program. So I mentioned that because over the last 12 years I was able to do that with my associates. And what that tells you is that not only you're able to be trained in these things, but also you'll be trained to be able to develop yourself and progress more down in your career. So I have a list of the things that you'll be exposed to and trained on right there. But also I want you to know that there is we have an interventional fellowship dedicated, and we have a structural fellowship dedicated. So if you have interest in pursuing further in the cath lab training, you have the opportunity here, and you'll have plenty of training in that as well. So everybody will finish his fellowship very comfortable doing diagnostic catheterization. And you'll see throughout your training all these other modalities, the imaging, PCI, a lot of high-risk PCI, Impella assist device, the biopsies, cardiomems, pulmonary pressure monitoring, and pericardiocentesis. And you'll participate in most of those procedures to a certain degree, depending on your progression, first year, second year, or third year. You could be part of a small part of the procedure. You could be part of the whole procedure, depending on, what year you're in and how much you're interested. But there's a lot of things to learn. ASD and PFO transcatheter closure, the PFO volume have picked up significantly. ASD is steady, but there are always interesting cases with the structural because there's a lot of hemodynamics, a lot of things to learn and see, whether it's imaging, angiography, or hemodynamics. The left atrial appendage exclusion, we're very, very busy with the Watchman left atrial appendage closure, and we do between 10 cases a week, I would say, on average. Valvuloplasty has been mostly replaced with transcatheter valve replacement. We still do valvuloplasties. But the transcatheter valve replacement, our program have done about 500 cases last year, so we're one of the top programs. And we've been doing that since 2011. We have almost all the platforms, the commercial ones, we have them, the core valve, the Sapien, and the Portico valve, and we use them all. And we also have investigational devices, the Portico and the Accurate Neo. The mitral clip and the tricuspid clip, we do a fair amount of those cases as well, about 4 to 5 cases every week. And once in a while we do some paravalvular leak closure. So those are very interesting cases to be part of at some level in terms of learning the hemodynamics, the imaging, and the clinical evaluation treatment of these patients. So you'll have plenty of exposure and things to learn from because of the variety and the complexity of these procedures that you'll be part of. So I'll just, break the routine with some cases to give you an idea of what it looks like to be a cardiology fellow in this program. This is a typical patient with triple vessel disease, an elderly man with kidney dysfunction, heart failure. Was transferred here for a multi-vessel PCI with Impella assist. So we got a radial access. You can see the catheter coming from top, injecting the dye, showing the iliac artery to be a good size, and Impella goes in, and we fix his triple vessels with Impella assist. So there's two axes, there's femoral, there's radial, and that shows you how you'll be comfortable with all type of accesses and intervention and assist device. Another case came from the Fellows Clinic, patient diagnosed with asthma, but turns out that this patient had an ASD, and this is his, actually her intracardiac echo showing a shunt right to left. This is the intracardiac echo catheter. This is the balloon sizing and measuring the width, and that's the device deployed using intracardiac echocardiographic guidance, and this is the device released. But not only just images, but also the shunt calculations, step up in the saturation, the pulmonary hypertension evaluation and whatnot. So it'll be part of evaluating these patients before in the clinic, diagnosing them, deciding who's going to need the closure and who's not, who's a surgical candidate and who's a transcatheter candidate, and going through the procedure, imaging and hemodynamics, and then seeing those patients after. So you have a very broad training in terms of treating those patients. Move on to the transcatheter valves. This is the patient with, as you can see on the 3D transthoracic echo, there's a thickened aortic and mitral valve. So this patient was sent for open heart surgery. And as you can see, she has a porcelain aorta here, so she wasn't a surgical candidate. And we went ahead and, this is a transesophageal echo that shows both the mitral stenosis here and aortic insufficiency and some stenosis as well. We went ahead and did a transcatheter double valve transapically here. We wrote that case because that was the first case where we did native mitral valve replacement in addition to aortic valve replacement. So just to show you of the different things that are done here, and you know, the sky is the limit of what you would be exposed to in this program. This is a patient with severe mitral regurgitation on his transesophageal echocardiogram, LV dysfunction, elderly male with class 4 heart failure. And he was sent for a mitral clip. He ended up getting 3 clips to be able to reduce his regurgitation to mild. Dramatically got better, class 1, doing very well. So, you know, these patients before, during, and after, I think the key is that you're able to see them at all these levels and understand the therapies and the evaluation and the treatment. So again, as a summary, the slide summarizes that the structural heart intervention has improved actually the fellows teaching significantly, because you're going to be interfacing and exposed from different aspects to this structural heart intervention, whether the clinical evaluation in the clinic before or after, the hemodynamic assessment with the cath lab, and then the echo imaging, which is, you know, could be part of the interventional training, or the cath rotation with the TE during the procedure, but also before or after. All these watchman patients get an echo at 45 days, a TEE. So you're doing all these procedures before and after, so you get plenty of substance to learn from. Then, of course, the coronary angiography in most TAVR patients, if not all of them, will get an angiography. And also, in addition to that, you get everybody with angina and whatnot. And then all the patient get CT or IVUS imaging. So imaging is actually a very important structural heart intervention, and that will bring you to a different level in your training. And then the intraoperative guidance is the most fun, actually, doing these cases. So I think you're going to be well trained in all these aspects, and you know, this program offers you all these opportunities. So good luck, and hopefully you'll come here.